Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. Today we're going to review cardiac ECG dysrhythmias and arrhythmias and maybe associate them with advanced cardiac life support interventions if required. What we're going to cover in this session will include sinus rhythms such as sinus rhythm, sinus tachycardia, sinus bradycardia and sinus arrhythmia. Now, sinus rhythm is the baseline, and in an adult, it's a regular rhythm at a rate between 60 and 100 beats per minute at rest with a normal PQRST complex. Sinus tachycardia is just a little bit faster. Tachy, fast. This is a fast, regular rhythm at a rate greater than 100 beats per minute in an adult with a normal PQRST complex. And it's normal. It's typically associated with sympathetic nervous system stimulation, your fight or flight response, exercise, but it can be abnormal in anything that causes you any distress. But if you're being caused and having distress, then it could be a normal response to that stress. Sinus bradycardia is a heart rate less than 60 beats per minute, which is slow but regular. And it's got a normal PQRST complex, and it's normal. It's because of parasympathetic nervous system stimulation, sometimes referred to as the rest and digest system, and may be common associated with sleeping. But it can be abnormal in relation to when you're vomiting, nauseated, or that you have acquired heart disease or just getting older. Sinus arrhythmia is really just an irregular sinus rhythm. So sinus arrhythmia means irregular rhythm. So this is an irregular rhythm at a rate between 60 and 100 beats per minute with a normal PQRST complex, but it's irregular. And typically, in an adult, it's normal. It may be associated with physical fitness, sleeping, and even normal breathing patterns. Now let's move to the supraventricular dysrhythmias. Dysrhythmia just means different rhythm. Supra, above the ventricle. Look at the diagram. Now, supraventricular dysrhythmias come from the atria, but they've got a different shaped P wave, or they may have no P wave because they're not coming from the SA node, the sinoatrial node. So supraventricular dysrhythmias that we're going to cover today are premature atrial complexes, atrial fibrillation, and atrial flutter. Now, a premature atrial complex is exactly that. It's a premature beat, which means it's early. And if it's early, it makes the rhythm irregular. And if it's not coming from the SA node, then it makes a different shaped P wave. It still has a narrow QRS complex, less than 3 small squares or 0.12 seconds. Have a look in the rhythm strip, top strip. 1, 2, 3, 4. The fourth beat is premature and it has a different shaped P wave, but the QRS complex is basically the same. Is it pathological in an adult? Probably not. It's usually associated with physical activity, being excited, drinking too much coffee, cigarette smoking. In abnormal situations, may be related to hypoxemia or electrolyte abnormalities such as hypokalemia or hypomagnesemia, and maybe in conditions where you have thyroid problems like hypothyroidism. But essentially, they're not problematic in an adult. Atrial fibrillation, exactly as it says. The atria are fibrillating. They're not contracting. And this creates a very, very irregular rhythm, very, very irregular, very irregular on your ECG paper. There are no visible P waves. It's got a wiggly line called a fibrillatory line. The atria, which you don't have to measure, are usually fibrillating at about 300 to 700 fibrillations per minute. The ventricle rate can be fast or slow, but not as fast as the atria. So therefore, when you look at the top rhythm strip, the grey one, you can see the atria have just a wiggly line. You can't really see any P waves. The QRS complexes are all narrow, but they're very, very irregular. And this is typically associated with acquired heart disease and getting older, congestive heart failure. The top rhythm is often referred to as fast AF, fast atrial fibrillation. The bottom one is more controlled, and we'll just call it slow atrial fibrillation. This patient's on medication. Have a look at it. If you count how fast the heart rate is, 1, 2, 3, 4, 5, 6, 7, in a 6-second rhythm strip, 70 beats per minute. It's irregular. There are no visible P waves. The QRS complex is narrow. This is slow AF or controlled atrial fibrillation. Atrial fibrillation. This is atrial flutter. Have a look at it. Atrial flutter can be regular or it can be irregular. The top rhythm strip is regular. But have a look, there are no P waves there. There are what are called sawtooth shaped P waves. And the atrial rate can be very, very fast, and the ventricular rate can be variable. The ventricular rate in the bottom one is irregular. And I'm not going to describe and go through the different blocks. If you want to learn about those, go to the Advanced ECG workshop or Learn shop that I have in other sessions. But atrial flutter can be regular, typically it's regular, or it can be irregular. And you recognise it by the sawtooth shaped P waves on the rhythm strip. And this is typically associated with heart failure or heart disease or getting older, similar to atrial fibrillation. Now let's move into the ventricles. Now the ventricles have got arrhythmias and dysrhythmias as well. But ventricular dysrhythmias, different rhythms, originate in the ventricles. There's no P wave. They are wide. The QRS complex is wide. The ventricular dysrhythmias, if they're premature, make the rhythm irregular. And they look really strange. You've got an idea of what the normal looks like. Look, there you've got on the rhythm strip there, P, QRS complex. But the one following is wide. One is positive and one is negative. But they look strange and they look bizarre. Bizarre means very, very strange. So when we look at ventricular dysrhythmias, what we're going to look at today are premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, and torsades de pointe, PVCs, VT, VF, and TDP. Now, a premature ventricular complex or contraction is, as it says, it's premature. And because it's early, it makes the rhythm irregular. It doesn't have an associated P wave with it, and the QRS complex is greater than 3 small squares or 0.12 seconds. Have a look on the rhythm strip. Second beat is premature and wide. Seventh is premature and wide. It's associated typically in normal people with physical activity, being excited, drinking too much coffee, cigarette smoking, some sort of problem in your heart, structural heart disease, hypoxemia, electrolyte anomalies such as hypokalemia, hyperkalemia, hypomagnesemia, hypermagnesemia, and maybe even disorders such as hypothyroidism. Ventricular tachycardia, monomorphic ventricular tachycardia basically means mono, one, morphic, shape. So look at the ventricular tachycardia in the rhythm strip. They all have one shape. They're all negative. And this is a chaotic, regular rhythm because potentially it's life-threatening. It has a wide QRS complex greater than 0.12 seconds, no P wave, and the rate, like for any tachycardia in an adult, is greater than 100 beats per minute. And typically, it's associated with acquired heart disease, the acute coronary syndromes, getting older, low potassium, high potassium, low magnesium, hyperkalemia, hypokalemia, hypomagnesemia. Then you've got ventricular fibrillation. Ventricular fibrillation, this is where the ventricles are fibrillating. So typically you won't have a pulse. Pulseless. The waves are coarse, big, or they're fine. There's no P wave, there's no QRS complex. The rate, which no one is going to measure, is typically very, very fast. It's fibrillating very, very, very fast. And typically it's associated with acquired heart disease, the acute coronary syndromes, age-related, low potassium, high potassium, low magnesium, electrolyte anomalies, hypokalemia, hyperkalemia, hypomagnesemia. Life-threatening. Then you've got torsades de pointe. Torsades de pointe is French for twisting of the points. And this is a very chaotic, irregular rhythm. Waves can be coarse and fine at the same time. Big, small, positive, negative, no P wave, no visible QRS complex, and the rate is typically very, very fast, possibly around about 300 beats per minute. It's associated with conditions that are congenital, such as things called prolonged QT syndrome, profound bradycardia, acquired heart disease, getting older, more than 65 years of age, and typically it's associated with electrolyte anomalies such as hypomagnesemia or hypokalemia. And it's got a classic picture. Look at it. Small, big, small, big, small, big. Twisting of the points. This is asystole. Asystole means no contractions. A means without. So there's no rhythm, there's no P wave, there's no QRS complex. And this is associated with end-stage cardiac disease, severe hypoxia, gross acid-base derangements like pHs of 6, 7, major electrolyte anomalies, hypokalemia, hyperkalemia, hypomagnesemia. A straight line, a flat line. Asystole. Now let's review briefly adult life support. This is basic life support. Remember, the brain cannot survive without oxygen or glucose. So you've only got about 3 minutes without oxygen or glucose before the brain damage occurs. Cerebral hypoglycemia, anoxia may cause irreversible brain damage in greater than 3 minutes. That's what you have to remember. When we look at resuscitation and basic life support, there are certain steps that you've got to follow. Step 1, Scene safety is for you and the patient. Look around, take 30 seconds. If it's safe to proceed, proceed. If not, review your options. Step 2. If possible, use standard precautions like personal protective equipment, rubber gloves, to protect you from body fluids, especially if there's trauma. Step C. Determine responsiveness. Hey, are you okay? If there's no response, activate the emergency medical response system to obtain advanced life support requirements. Determine responsive means take only a short period of time, no more than 10 seconds, to look for signs of life. Are they breathing? Are they moving? Are they responding? If not, activate the emergency medical response. You can check the carotid pulse in an adult, but don't take more than 10 seconds. No pulse means no circulation, or if you think there's no pulse, they don't have a circulation. If there are no signs of life, and that may include taking a pulse, depending on your level of expertise, then commence CAB. CAB compressions, push hard and fast on the centre of the victim's chest. Airway, tilt the victim's head back using the head tilt chin lift manoeuvre. Open up the airway to maintain the airway, and then commence breathing, giving mouth-to-mouth rescue breaths. CAB is the acronym we now use compared to ABC previously, before the 2010 recommendations, because again, we want to start compressions early. Compressions are hard and fast. Hand placement is between the nipples and the intermammary line. Compression rate is hard and fast, or 100 to 120 compressions per minute, but hard and fast is fine. Compression depth, a third of the anterior posterior chest wall in an adult, which is about 2 inches. Make sure that you push down to a third of the anterior posterior diameter. This empties the heart systole. Make sure you allow full recoil, filling, that's diastole, of the heart with blood. Pushing down empties, relaxing fills. You can do it with 1 or 2 rescuers. The compression technique can be one hand, heel, mid-nipple line. 2 hands, heel, mid-nipple line, as the diagram indicates, pushing hard and fast. Open the airway means exactly that. You open the airway performing the head tilt chin lift manoeuvre. Place one hand on the forehead, the other hand fingers to lift the jaw, and this pulls the tongue and the epiglottis up, opening the airway. Breathing, you breathe for the victim, they can't breathe. So mouth-to-mouth breathing, seal and pinch the nose, give 2 breaths over 1 second each. Not too quickly, not too slowly. If you've got a bag and mask, you can do mouth to bag or mouth to mask or bag to mask, and you seal the mouth using the E grip, C grip. And you give 2 breaths, both over 1 second each. That's an example of the E grip to elevate the jaw, the C grip to push down on the mask, to seal the mouth, if you're using bag mask ventilation. If you're having difficulty and you've got another provider, then they can do a double, 2 rescuer, E grip, C grip, and the other person just ventilates. With cardiopulmonary resuscitation, the compression breathing ratio is 30 compressions to 2 breaths. You do 5 cycles every 2 minutes, and then you check the pulse. Every 2 minutes, it's recommended you change roles because the person giving compressions may be getting tired. Now let's move on to adult life support. With adult life support, ACLS, there are further recommendations. I'm not going to go through all these, but you have devices called the oropharyngeal airways, and these are only for unresponsive, unconscious victims. They maintain the airway, they don't protect it. Insertion, you can measure from the corner of the mouth to the angle of the jaw. That will indicate the correct size. You insert the tip along the roof of the mouth, along the hard palate, soft palate, then turn 180 degrees until it rests on the lips. The flange then rests on the lips. But this is only used in an unresponsive, unconscious patient. Nasopharyngeal airways are for responsive, conscious victims. They also do not maintain the airway, they do not protect it, but they do allow suctioning to clear the airway. Insertion procedure is to measure from the tip of the nose to the ear tragus. You insert the tip along the upper nasal wall, rotate gently till the flange rests on the nares, and a lubricant is recommended. Circulatory adjuncts can be IV or intraosseous access, advanced airways, transcutaneous pacing, cardioversion, defibrillation, and medications. There's your intraosseous, which can be used for adults now as well as pediatrics. Emergency medications, fluids. When we look at advanced airways as adjuncts, we have the laryngeal mask, tracheal tubes, suction devices, end-tidal CO2 monitoring or capnography. But again, we're just going to review them briefly. We're not reviewing these in this Learn shop because it requires additional skill and training to insert these objects, these airway adjuncts. Here are examples of tracheal tubes, but they require expert consultation to insert, not reviewed in this Learn shop. Tracheal tubes, remember, are not a priority unless breathing cannot be provided by bag mask ventilation. Bag mask ventilation is very, very effective, but it's not a priority to insert an endotracheal tube unless the resuscitation isn't going well, or the patient's about to be transferred to the intensive care, or you cannot maintain bag mask ventilation effectively. Suction catheters are very important to keep the airway clear. You've got oropharyngeal suction catheters for the large airways, and you've got smaller ones for the tracheal tubes. You've got end-tidal colorimetric carbon dioxide detectors, and they can now ensure accuracy for tube placement after tracheal tube insertion. You've got defibrillators. In BLS, you have the AED, the automatic external defibrillator, which BLS providers can use, or you've got the manual ACLS providers, manual defibrillators. Defibrillators as an overview, you've got monophasic defibrillators, and typically you'll deliver a first dose of 360 joules and subsequent doses of 360 joules. Then you've got biphasic defibrillators that deliver energy in two directions. The first dose typically is 200 joules, and subsequent doses can go up to 200, 300, 360. You've got two types of techniques, which is called hands-on paddles or hands-off paddles. Both are effective. As far as differential diagnosis goes, the mnemonic, when defibrillation is refractory, you've got the 7 H's, which means what can stop the defibrillator from working properly to revert the rhythm? Hypovolemia, hypoxemia, hypokalemia, hypokalemia, hypoglycemia, hypothermia, hydrogen ion acidosis, which can be both metabolic and respiratory. Then you've got the 7 T's. Defibrillation is not working for some reason, it's refractory. So you've got trauma, which can be surgery, cardiac tamponade, tension pneumothorax, thrombosis, which can be coronary artery, STEMI, or pulmonary embolism. Can be overdose of certain medications like beta blockers, calcium channel blockers, toxic medications, or it can be after cardiac transplant. What are some of the medications that we might use in resuscitation in ACLS? Oxygen, probably the most important resuscitation medication with effective CPR. Epinephrine, another important medication, and the dose will be 1 milligram every 3 to 5 minutes. No maximum accumulative dose. You've got vasopressin, which is another important medication for resuscitation. However, you only give one dose, 40 international units, one dose only, and this can be used as an alternative for the first or second dose of epinephrine, but after that first dose, you resume epinephrine 1 milligram every 3 to 5 minutes. Then you've got amiodarone. Amiodarone is a very effective broad-spectrum antidysrhythmic, and typically for now ventricular tachycardia, ventricular fibrillation, or refractory to defibrillation, it's 300 milligrams, and a second dose can be given 150 milligrams. And it's very effective because it's a class 1, 2, 3, 4 antidysrhythmic. Atropine is typically recommended for symptomatic bradycardias. However, it's no longer recommended for asystole or pulsus electrical activity. And the dose is typically going to be 0.5 milligrams to 1 milligram every 3 to 5 minutes to a maximum dose of 3 milligrams. Calcium chloride typically is now used for hypocalcemia, hyperkalemia, calcium channel blocker overdose, magnesium toxicity, beta blocker overdose. And typically it's given 1 gram, no maximum dose. It's at the doctor's discretion or the team leader's discretion. Then you've got magnesium sulfate, which is typically used for torsades de pointe. But it can be used for refractory ventricular tachycardia, ventricular fibrillation as well. And the dose is typically 1 to 2 grams, with a maximum dose of 2 grams. And finally, we have sodium bicarbonate, which, if indicated for prolonged arrest, metabolic acidosis, we can give 1 milliequivalent per kg of an 8.4% solution. That's the end of this session. Thanks again. If you found this session beneficial, please recommend it to your colleagues and your friends and subscribe. See you in any future Dr. Manny Learn shops. Take care and God bless.